And I think that when I first came in, the first bit of information that I would get, I'm like, oh my gosh, the BMI, and kind of like hyper focus on that one thing, or like, oh, they became vegetarian in the last year or so. So I'm like, oh, B12, zinc, and like kind of,
Mhm.
losing track that the problem is malnutrition.
Welcome to podcast 3. Where is your destination? Today's podcast is going to cover in the first 15 minutes the essence of where we're going. what are the various things that we want you to be supported with and understand and know about eating disorders from someone who's been again in the field for a while, and for you, like what's been helpful for you and what hasn't been helpful for you, maybe from even the residency in my practice. And then we're going to go in more depth into the beginning of that series or topical information. And today it's going to be free. So we want you to see if this is helpful for you and useful. That'll be the last 30 to 45 minutes of our discussion today. So, deciding the road and pathway. There is so much to know. Where do you start? Where are we going? All those types of things. So, various things in my mind that I think about of where we're going is I know that you want to understand conceptualization of eating disorders. What are you looking at in the room? Understanding them. So you got to know basics, right? I remember a long time ago, I won't name the university, but I went to university and asked if I could possibly do a 1 hour topical class, kind of like the University of Houston does, on eating disorders. And they're like, no, we don't do that. We're more science based. We don't have enough CEUs to offer, or not CEUs. We don't have enough hours for our undergrads to take. We have too many other classes that they can take. Of course, one of the classes that they offer was on obesity. It was a 1 hour education on obesity. I'm like, okay. But I remember being told, like, we'll just have them come in and just observe you. That'll be a great way of learning. I'm like, no, they need to know basics. You got to know what you're looking at in the room when you when you start treating eating disorders. So we kind of were brainstorming, Mateus and I, about, okay, how do you conceptualize? You got to understand a diagnosis for sure. You have to see how they're presenting in session, those various things. A lot of medical issues that can kind of come up. So we're going to kind of go in that direction as well in some of our different podcasts that are upcoming. We also want to make sure you have skill sets, right? Like motivational interviewing, Socratic questioning, how to build trust in the room, the therapeutic alliance, all this various things. So we'll have various topics and podcasts on skill sets. Then we want to go into kind of therapeutic modalities, like what's helpful for a dietitian to have. I mean, I did mention motivational interviewing, but there's a lot of therapeutic modalities dietitians can be trained in and understand efficiently to really utilize a little bit in their rooms and to support the therapist, and many, many other pathways in this destination. Mateus, what are the things that you're thinking about? This is kind of an overview of where we're going in
Yeah.
this destination.
I think that the way that I see it is I reflect about the confusion, that I found myself in, not only with the the emotional side of it, that comes with eating disorders, but also how to approach the medical piece too, because I feel like there's so much emphasis on weight loss and weight management and all those things that we, especially here in the United States, it becomes harder to identify and to pay attention to signs of malnutrition. I feel like malnutrition is something that is really overlooked here, because when we think malnutrition, we think about developing countries, children, but we don't think about the adult that is over exercising and not eating enough, because of that fear of gaining weight and stuff like that, and how there are so many aspects of clinical presentation. The tellers all this time to me is I hear parents just telling me like, oh, before I landed here, I went to 10 different doctors, different specialties, trying to figure out endocrinologist, orthopedic doctor, adolescent medicine, GI doctor, trying to figure out what's wrong. And the underlying cause was the malnutrition that comes with having an eating disorder,
Mhm.
So being able to see some of those signs, I think, is very important and very confusing at first.
Mhm. No, that's excellent kind of description of oftentimes what you'll see coming in the room where there's all these complaints and this is they're exhausted and tired and at wit's end trying to find some answer, and it seems so obvious when they walk in the room and you're like, oh gosh, this is exactly probably what's going on. And sometimes it hasn't been, but the majority of times it generally is some sense of malnutrition that is causing a lot of these effects. And unfortunately, a lot of interventions are done on individuals with malnutrition that don't need to be, like putting pacemakers in or having uh, a GI series done when it's not necessary. Those various things that are expensive and time consuming and doesn't really address probably the underlying issues of malnutrition. So let's first start with malnutrition. Let's dig into that and what is malnutrition? And of course, we're going to dig into eating disorders as well. But I think it's a helpful to really understand what's in front of you. And that oftentimes what we're dealing with is the essence of malnutrition, and dig deeper into that and give you some resources and understand from both a therapeutic standpoints, if you're a therapist joining in, but also for a dietitian to understand what you don't know and to be able to look differently in those presentations that we see oftentimes. So join us on the back end for 30 minutes or 45 minutes and let's learn more about malnutrition. All right, let's dig deep into malnutrition a little bit more. And we're covering some topics and information that we think is probably most helpful. But of course, there's loads of information and so much to know and understand. So we don't want this to be limiting, like, okay, the learning stops here. It doesn't. We hope that this is the beginning of your learning. And again, and enhancing the destination and towards your journey to eating disorder expertise. So, how is malnutrition missed? And what do we need to be looking at in the room? So, Matthias, I'll let you start off a little bit here.
Yeah. So I think there are a few ways that we can miss out on malnutrition. I think that to especially in the United States, when people talk about malnutrition, we think of like underserved communities, we think of developing countries. That access is the problem, access to food. And what I've noticed in this field is that access, most often than not, is not the issue
Mhm,
here. It's that societal praise for weight loss that makes it, like I hear a lot from parents that come in that they've gone through several specialists trying to figure out what was going on with their child because they're having GI issues, because the growth is stunted, because mood issues are arising and all those things. And they finally find the answer that the body is just not functioning because it's not getting everything that it needs.
mhm,
The
mhm,
body is struggling to keep up. So malnutrition can look like IBS symptoms. Malnutrition can look like emotional dysregulation. Malnutrition can look like um, an athlete, that is working out for long periods of time, but it's not feeding enough, and looks very healthy by what society expects,
but has
of
poor
people,
performance.
but is having poor performance,
Mhm,
hasn't had a period in God knows how long.
mhm,
So these are some of the things that I think that will be interesting to discuss,
mhm,
because those things can be confusing sometimes because a lot of them are praised as, metrics of success. Oh, you lost all this weight and stuff,
mhm. Absolutely. Definitely food insecurity can be a big part, right? Even in food deserts or individual places where there's not, a close grocery store, individuals have high access to fast food or various things like that that may not have high nutritional density. So you see a higher weighted body, but in individuals that's pretty severely malnourished because they're only getting maybe one meal a day in or not having any access to fruits and vegetables or those things like that. So I don't want to dismiss, the food deserts and food insecurity and things like that. But with eating disorders in particular, we definitely see malnutrition missed often, like you said, because they've gone through multiple other providers until they're landing here. And that's what we want to really kind of emphasize, is that when you know what you don't know and you learn and you understand what you're seeing in the room, it's very clear about what's going on. And I know that we've had several sessions together, and a lot of times I might kind of I remember at the beginning would redirect you towards, okay, you're going down a rabbit hole that is very medically oriented, and I mean your knowledge in medical information is supreme, yet you were going down one area where I was kind of seeing the malnutrition piece in these other areas. And so I feel like now you blend it so beautifully. Both you see the malnutrition and you have a really strong medical background. One day you'll have to talk about on the podcast your training in Brazil and how different it is than dietitians in the United States. So, but yeah, malnutrition is so missed for sure. So we want to, make sure that, when you're seeing those various things, the multiple providers, stunting of growth, emotional dysregulation as parents, kind of like my child is not the same, those types of things. It oftentimes doesn't look like cachexia, right? Where of course there's temporal wasting, and we'll talk a little bit more about that. But a lot of times you can even see a child that was maybe originally on the 85th percentile and now is on the 50th, and they walk in and they look kind of normal. Yet there's a lot of stuff going on. And because they've lost 20 or 30 pounds and they've fallen off their growth chart, for example. So, so malnutrition is missed often, and we'll dig more into that a little bit more. But those are some pure examples where you won't see someone walking in that looks like they're walking on, toothpicks, for example.
Yeah. And you mentioned something that I think needs to be emphasized. BMI by itself, it's not a great metric for malnutrition assessment. And someone based on BMI standards can be obese, overweight, and still have
Mhm.
severe protein calorie malnutrition, not only micronutrients, but actual and not actually not getting enough energy. I've worked with clients that they started out at those higher BMIs and they would lose 20 pounds, still be in a higher BMI, and be very medically compromised.
Mhm.
So that is something that I think within the field, it's probably the one thing that is missed the most, because there's a lot of stigma around, being a larger body and all those things, and dismissing the idea that maybe that person's not eating enough,
Mhm. Mhm.
you know, uh, in those atypical um, anorexia cases and all that.
Mhm.
So again, larger people in larger bodies can be malnourished too. Don't dismiss that.
Yeah, someone coming in with 150-pound weight loss, and they have so many cognitive distortions. They have low blood sugar, for example, low blood pressure, multiple things are going on. And that's such a challenge. I think we won't delve greatly into the BMI, but BMI is important too in the field. I think it's oftentimes being dismissed as any kind of clinical use. I definitely think that BMI can still be used to dig deeper, right? Even the diagnostic, and we're not going to dig into that today, but the diagnostic criteria for anorexia nervosa begins to show the different severity levels based on BMI, for example. And some people don't like to see that in the DSM-5, but I think it's still helpful, right? That a lot of times I don't see, being in the field as long as I have, it used to be that you want to get someone to a BMI of 20 minimum for anorexia nervosa. That used to be kind of some of the criteria we would look at. We've moved beyond that, but BMI, I definitely don't see individuals recover that often when they're hovering at a BMI of 18 or 19 and they're coming up from a BMI of 16, for example. So we want you
Yeah.
as a dietitian to still use BMI, I think, to look and see, like, on growth records and charts for adolescents and pediatric clientele that you see, to also just informing and getting more information from adult clients that you see that went from a BMI of 80 to a BMI of 50, like you're mentioning, that, are still at a high BMI, quote unquote, yet are severely malnourished. So there's many things and criteria that you can look at. But BMI, having them come in the room, don't be fooled by someone that looks, quote unquote, normal or fat or overweight or high BMI, and only be looking for individuals that, look the part of malnutrition that we oftentimes think about with anorexia in particular.
Yeah.
So, what do you look for outside of, we talked about kind of behavioral things, parents being distraught, multiple providers that are dismissing underlying issues that are going on. So I'm looking at my notes here. There's other things you can look for, right? And so one of them is the nutrition focused physical exam, which I'm not trained in. I know, Mateus, you are. And so I'd love for you to kind of delve into that a little bit more. Some people are just virtual platforms. So I think it's pretty hard to do that type of assessment, but let's dig into that a little bit more as one way that can be very impactful, important to look at. I'll let you start.
Yeah. So the nutrition focused physical assessment is basically trying to see the body as a whole, and it can assess both fat loss and muscle loss. And I think the muscle loss is particularly important because it's where I see the most um, medical complications arise from.
Mhm.
So not when I'm working virtually, you can still do it in a way because there's a visual component to it, but the physical assessment is actually touching the person, like the temporal, and feeling for the fat pads and muscle wasting. So a person that has lost a lot of weight, this area tends to be very hard because the muscle also depletes, and it's something that we'll talk about too. There's this sign over here that when this is kind of there's a depression instead of like a bulging of the muscle, it's also a sign of muscle waste. And this is particularly interesting because it can still happen, especially if you're able to touch it, it can still happen for a person that has a lot of fat, a lot of adipose tissue. Because when you do this, what's really bulging is the muscle underneath. So it's still interesting to look at. So the shape of the shoulders, more squared off shoulders, the protrusion of the clavicle bones is also one to look at. The cheekbones and the depression around this area. There's a really great resource from the Academy of Nutrition and Dietetics is a nutrition focused physical exam pocket guide, and we're going to add that to the notes, the podcast notes as well. And the reason why I really like the resource is that it not only covers the protein calorie malnutrition and like those signs, but it also has some signs of vitamin deficiencies too, and it has pictures for everything,
Awesome.
which is very interesting. One of the signs that I've seen in anorexia, for example, like very severe malnutrition, is lanugo, which is like baby hairs kind of growing all over the body. And that is on that guide is one of the severe malnutrition signs too.
Mhm. No, that's excellent. And that can be challenging again in virtual platforms. So, but a lot of times you just see the upper body, or maybe some people carry weight differently and you don't really notice until they stand up, those types of things. So, so we want to make sure you have all realms of ways of looking at malnutrition. Because if you're not really able to see a person face to face, then you're not able to kind of do some of the things you're talking about outside of just seeing their face, for example. The other thing I want to mention too is the knuckles, when the knuckles get really, protruded and there's less space. And if you're not seeing us on video, we're showing on video, there's more space in between the knuckles. And then veins are showing quite a lot around their arms and hands. You can kind of tell a lot, at this point in my career, I've seen so many individuals from, moderately to very severely malnourished. And so it's kind of like buying a white car and then all of a sudden you see white cars. Everyone has a white car, on the road. And that's how I see at this point, individuals with malnutrition. Of course, I look at other data, but I can quickly tell through what I read, asking certain questions, and then looking at them where they probably are on that spectrum a little bit, and to their behaviors and thought patterns, things like that. Labs are other ones that can be confusing, and that's frustrating, I think, in this field because a lot of times we want to make sure that they're getting medical evaluation and support, but when they go in and they get a full lab panel, that many of the labs look normal, and then the doctor tells them, "Oh, things are great and normal," you know, and so then you're like, "Oh, this is a problem." So, we want to make sure that, you understand that the body is really great at keeping us at equilibrium, and so you rarely see abnormal labs because the body is trying to adapt to malnutrition. It's an adaptation to malnutrition. And so the more and more malnourished they get, the labs stay really pretty stable until guess what? You add food. And then they can kind of crash and burn, which we'll talk about in other podcasts as we go along. So labs can be challenging because they're not really indicative sometimes of malnutrition. But certain things that you can look at when you have some anemia with an adolescent or an adult, like that's really rare. Sometimes if they have excessive menstrual bleeding or something like that, or a GI bleed, you might see some anemia, but generally anemia is rare. So a lot of times you want to look at, do they have cancer or do they have an eating disorder, especially when they relatively should be okay and nourished. So anemia can be a big one that you can look at. A little bit of low blood glucose can be there as well. You might see some slightly depressed glucose levels that are there. And then also sex hormones, that those can be non-existent or gone. Those are things that you can be looking at. But even someone that's purging, right? Unless they abruptly stop purging, for example, you won't see oftentimes potassium or various things that are off even then when they're actively engaging in that. Not always, but a lot of times. So those can be a little bit misleading, for example. Again, you want to get labs done, and see. And then especially if you can compare to labs that they had previously, maybe the year before or a couple of years before that they maybe weren't engaging in their eating disorder, that can give you some information as well. But you can get some frustration from doctors that don't know how to interpret them and know what they're looking at for sure.
The body's really good at, masking a lot of those things. You're not going to see low calcium unless there is a metabolic abnormality,
Mhm.
even if that person is not consuming enough calcium because the body's just taking away from the bones,
Yep.
And this is how a lot of the complications around malnutrition kind of arise is the body is trying to keep the brain functioning and the heart beating and kind of messing everything else
Mhm.
up in the meantime. Um, the Minnesota starvation study, for example, was a really interesting one that where they starved subjects for a limited period of time and they tracked, muscle tissue, fat tissue, heart. They also tracked mental health, obsession with food and sexual drive and all sorts of different things. And then they did a refeeding period after, and kind of compare the findings. And the whenever you're starving yourself, um, your brain doesn't really run on fat. You're breaking down fat tissue, and that's feeding other parts of the body. But the brain still has with the brain barrier and all those things, has a really strong preference for glucose. So it's going to start breaking down protein, converting amino acids into uh, back into glucose to stabilize blood sugar because that's what the brain needs. That's what the heart needs to keep on beating. And that process can be devastating for the rest of the body because the brain's going to be diverting. If you're having to use protein to stabilize blood glucose for the levels for the brain, the body's not only taking from skeletal muscle, from your arms and legs and all those things. It's taking away from the substrate that you'll be using to produce neurotransmitters, to produce enzymes. The lining of the intestine, the GI tract has a layer of muscle there too. So those are the confusing things that show up, like, oh, this person has been having IBS symptoms for this long.
Mhm.
They didn't used to be lactose intolerant. Now, every time that they have any type of dairy product, they have a really hard time. When they eat, it feels like they just stay full forever. So those are the things that we kind of hear. They're like, this is sounding like gastroparesis a little bit, maybe.
Mhm.
you know, um, and it's I'm not gonna lie, it's very challenging to have those conversations because in this process of trying to figure out what's wrong, the food is blamed so many times. It's like, oh, I'm having GI issues. Let's eliminate.
Mhm.
And it's very hard for people to trust, you know, and reintroduce some of those things back to.
Yeah, because they have diarrhea when they drink milk because they don't have enough nutrition on board to make, the enzyme to break up lactose, for example, like you're mentioning. So it can be scary for them to add back these foods and understand that process for sure. Yeah, I mean, when we look at IBS itself, I mean, I would say 40 to 60%. I think Dr. Philip Mailer mentioned this in a presentation that 40 to 60% of IBS issues we see very common in eating disorders. Yet still, only 3% of the whole population has celiac disease, really have issues with gluten, those types of things. So, when you have individuals come in that have gone to a naturopath and have been told that they need to avoid all these various foods, and then, they're avoiding them all, and things are getting worse and worse, like you said, blaming food, you can quickly see how malnutrition develops because they're eating less and less and less and less, either volume or macronutrients. They're eliminating a whole group, for example, and or various variety because of what they're afraid is going to happen to their GI system. So
Yeah,
GI disorders are very important to kind of really dig in deeper when they're coming in wanting to know what they need to avoid because of bloating that they're having versus like, do we have fundamental underlying malnutrition and how do we resolve that first? And then maybe we can kind of dig into maybe some food intolerances or issues later on. So I think that's
yeah.
important to talk about.
That's one some of
Mhm.
the things that I like this conversation that we're having to emphasize that there's no single thing that is going to be the thing that fits all. It's a holistic approach to looking at the BMI, at labs, at all sorts of different, at 24-hour diet intake and what they've been eating for the last several weeks, for the last several months. Because nausea sometimes is
Yeah.
because the blood sugar is
Mhm.
running lower,
Especially in the
and they can
morning.
get
If they're always
exactly they
nauseous in the morning, like, well, when's the last time you ate? Type of thing. Yeah.
yeah, so it takes a lot of reflection and like seeing at the looking at the different, you know,
Mhm.
and I think that when I first came in, the first bit of information that I would get, I'm like, oh my gosh, the BMI, and kind of like hyper focus on that one thing, or like, oh, they became vegetarian in the last year or so. So I'm like, oh, B12, zinc, and like kind of,
Mhm.
losing track that the problem is malnutrition. you know?
Yeah. And we want to roll that out, especially if you're an eating disorder practice and most people kind of start to, come in that direction, seeing that maybe this could be the thing, but they don't necessarily say that that's the problem probably, or they don't recognize it themselves for sure. So
Yeah.
yeah, I mean, it's kind of that presentation in the room, and this we'll talk again, probably more on just a general assessments when someone walks in your room, is to not assume, right? Your best teacher is your client. Remember that. Always going to be your client. So hear and listen to every various thing that they're talking about. And your job is to kind of I always talk about like you're going into this hallway full of doors and you've got to open up as many as you can without going too in depth, kind of pull back out and go look at the other door, whether it's BMI or labs or their history of weight loss, whatever it might be. There's so many little doors to hear and listen to in that first few appointments with a client so that you can fully assess, is malnutrition present? And because through the Minnesota starvation study, they can't do that study again because it's quite unethical the way they did it. But there's so many things we know about malnutrition and how it presents because of what these men went through. And so again, we'll have a link for you to read all about it. It's important. Many people know about it, but if you don't, that's a great place to start to really understand that, you'll see obsessions with food or cutting your food in small pieces or, various behaviors, with that, and including labs and things that Mateus went through a little bit that greatly impact, the essence of malnutrition being the first and foremost thing that you want to address and manage and support. So there's the Academy of Eating Disorders has what they call the Purple Book. Again, we'll have a link to that. And in the appendix, it's Appendix 2, they have review of mild malnutrition, moderate, and severe malnutrition. And so it kind of gives you very factual things to kind of look at, from BMI to the Z-score, if it's a pediatric, to how much they're eating and how much weight they've lost, the various things like that. So those are really great ways of looking at, a lot of things we talked about, but in addition to looking at how to categorize different levels of malnutrition. But, we don't want, and they also have labs, what may be low or high, depending on what you're looking at, with a client that has their labs taken, et cetera. But we don't want that to be kind of the end all. Like, okay, once I see that, then I know exactly how to assess it. All the various things that we talked about for sure are going to be important factors of looking at it. But that is another great resource to look at. Awesome. All righty. Well, that concludes our malnutrition topic in more depth. And we look forward to seeing you in our next podcast.